a common data frame or a common understanding model of the state of the patient, the health state of the patient. Based on these health states of the patient, we can make predictions, what happens with this patient over time, which phenotypes we will see, how will disease develop, and maybe we can also visualize these effects. In the end, we are interested in maybe defining certain patient populations, but also to make specific predictions. For instance, predicting a treatment that would maximize the survival of that patient. One problem with this in general is in precision medicine is that we don't have enough data to do this for many diseases. Intensive care is one special case where hospitals have taken measures to record this data over many years. We do have data from the last decade or sometimes decades where we have the health records, the drugs, the recordings of ICU monitors, and we have also outcome data. For instance, what happened with this patient after we measured it maybe a few hours later or a few days later. So intensive care is one of the few domains that has recorded large data sets that are suitable for machine learning. And what we were particularly interested in is to develop early warning systems of organ deterioration. So we're interested in what's the likelihood of an organ deteriorating in the next few hours. Or we are also interested in predicting what kind of treatment or what kind of procedure is suitable for treating this patient at a certain time point. So intensive care units are very data rich. We have different types of information. We have organ function parameters with respect to circulation, to the pulmonary system, the nervous system, the renal system, and also infection parameters. It's very dense in information, and it's difficult for a human to understand all pieces of information and make the right decisions. So there are different types of organ failures in the ICU, and we work on this with different collaborators. For instance, on sepsis, secondary brain injury, acute respiratory failure, acute kidney failure, and circulatory shock. So I will focus in the next part on circulatory shock first. So circulatory dysfunction, just 1 second, I have some disruption here. Okay, good, thanks. So circulatory dysfunction is defined as an insufficiency of the circulatory system where we have a lack of oxygen, and this leads to a shock, and this leads to further organ failure. So we define circulatory dysfunction as a sustained condition. This must be true, let's say, for 45 minutes, a sustained period of low blood pressure with elevated lactate. So for instance, 45 minutes, the following condition must be true. We must have low blood pressure and we must have elevated lactate. And this is the condition we would like to avoid and like to predict. So that's the task. And it's very important to avoid these circulatory dysfunctions, because when you look at the correlation between the circulatory dysfunction in a stay with the mortality rate, there's a strong correlation. So the longer the patient is in circulatory dysfunction, the more likely the patient is to die. So we'd like to detect these conditions early and avoid them. So in the specific setting here, we try to predict whether a currently stable patient will get worse in terms of circulatory dysfunction at any time in the future in the next 8 hours. So we have a window of 8 hours and we make predictions every 5 minutes. And the data looks a bit like this. So this is the arterial blood pressure, the heart rate, SpO2, and other measurements. And in this region here, this would be the circulatory dysfunction, which we would like to detect. And we would like to detect it a few hours in advance before it actually happens. So this is what you can, where you can use machine learning systems very well. And what you need to do is first, you need to get the clinical data in shape. You need to do data pre-processing. And for this, we get the data from the patient data management system. We get different tables. we got data from 54,000 patients. We got overall 64,000 measurements per patient per admission. And we have about 2 days of data per admission and 230 years of observations in total if you would concatenate all this data together. The tricky bit is to deal with this data and to pre-process it in a way that we get rid of artifacts, that we get rid of redundant representations, and have a compact representation of this data at the end. So there's additional steps needed, adaptive imputation and some annotation of this data. I don't go into detail here. But in the next step, we extract features, we label the time points, and then we use supervised learning. And this is a random forest model, which tries to predict whether in the next few hours there's going to be a circulatory failure or not. And at the end, we on a test set, we evaluate the system, and where we raise an alarm, and if the alarm corresponds to a true event, then this is a good alarm, a true alarm, and if the alarm is raised when there's no true alarm, then this is a false alarm. And from this, you can define precision and recall. So here's the definition. So this is a captured event. These are the 8 hours before the event. If there's an alarm, so this is the score the system produces. And if there's a true alarm within the 8 hours, then this event is captured. If it is much earlier than the 8 hours, then this is a false alarm. Or if there's no alarm right before or within the 8 hours before the event, then this is a missed event. And then we can compute precision recall. And as usual, in machine learning, we would train this on a training set and then test this on a test set. And we had a special design here to take to consider the temporal nature of this data. So we trained on data between 2008 and 2014, I think, in a cross-validation scheme in a specific way. And at the very end, we tested the system on the most recent 10% of the data. This would be the normal setting where you train on data which you had until now, and then you use it for the future. So this is the result which you obtain. This is the precision recall curve. So we are interested in a relatively high recall. We would like to get a large fraction of the events captured. So ideally 80, 90% is what we aim to get. And then we have a precision here, which is associated with this alarm system. And we would like to get the precision as high as possible. And we worked actually quite hard and got the precision to close to 50%, more like 45%. This means that every second alarm, roughly, is a true alarm, and the other one is a false alarm. And if you look at the recall independence of the hours before the event, then you see that the closer you get to the event, the recall gets larger. But in many cases, even 4 hours before the actual event, we can detect it with a high recall rate. So it's very important to understand what the system learns. And we have started with 4,500 variables from vitals and medication and lab tests. In the end, we reduced this to 209 variables, which have a possible clinical relevance for circulatory failure. And then we used machine learning to rank these variables and found the 20 most relevant variables for predicting circulatory failure. And these are the most relevant variables. Obviously, lactate plays a significant role, mean arterial pressure, how long the patient was in the ICU, which then there are certain drugs which are vasopressor drugs, which are very important and so on. And one can also use the Shapley values or the Shep values to understand the effect of different variables to the prediction score. If for instance, if the mean arterial pressure in the last hour is low, then the likelihood of a circulatory failure is significantly increased. Same as if the age of the patient is very high, then this also increases the likelihood of circulatory failure. Okay, so maybe with this, we see that a machine learning system can predict circulatory failure. So, so the performance depends actually a lot on the data set size. When you plot here the performance, the precision, for instance, as a function of the training set size, up to 100% of what we had, then you see when you had less data, then the performance would drop significantly. So we would expect if you would increase the data sets sizes, that this would lead to a significant increase in the performance. This motivates us to look into more data from other hospitals and so on. So the system performance is well enough, or performs well enough to be of clinical utility. So in a sense, we are quite happy with the performance of the system. However, there are many challenges for clinical use. So would the system actually really help in practice? So, and can we show this? Does this system work for all patient groups? Does the system work on other hospitals' data? How do we interface between this system and clinicians? And how can we actually practically bring this into the hospital from an IT perspective and also from a legal perspective? So there are many challenges, and I'm trying to address some of these challenges for this specific case by showing you some more results on this application. So the first one is maybe comparing our system with the typical or the current use of threshold-based alarm system. So a typical alarm system in the ICU setting would be to look at specific values, for instance, heart rate. If the heart rate is below 60 or larger than 110, then this would raise an alarm. Or if the cardiac output is below a certain value, then this would raise an alarm. So the difficulty with these alarm systems is that they raise many alarms. And when you look at the number of alarms per hour for such system, you would get about 10 alarms per hour. So every 6 minutes, you would get an alarm. And this easily leads to alarm fatigue. Somebody has to look for this alarm, silence this alarm, and next time probably doesn't pay much attention to the system anymore. So such a system would have a high sensitivity, but it would also have a very large fraction of false alarms, and actually more than 90%. So if we instead use our system with the standard recall rate of 90%, then we would have only 0.4 or 5 alarms for patients with events, and only 0.1 alarms for patients without events. So this is significantly better. So there will be an alarm every 10 hours for a healthy patient and every 2 hours for patients which has some issues, So it's much better, it's factor 10 or 20 better than the threshold-based alarms. So we also looked at the performance of different patient cohorts. We looked at cardiovascular patients, respiratory patients, neurologic patients, trauma patients, and so on. And we found generally the performance is, the prediction performance is reasonably uniform, but there's one subset of patients, the neurologic patients, which behave differently, and generally the performance for those is lower. So one has to be careful with those when applying the system. There's another complication. So one of the reviewers pointed out, and we looked at this in great detail, that a physician often suspects that a patient may deteriorate in the near future, and then the physician orders a higher monitoring density. So maybe the system, or the machine learning system, only detects that the monitoring intensity is higher than normal, and this is then used to predict the deterioration. So it's not actually using, not actually predicting deterioration, but only whether there is a higher monitoring density. So it's kind of imitating what the physician is doing. So, and what we looked at is looking at the system performance when we normalized for monitoring density. So essentially, we took the original data and we removed measurements, which to a certain regular grid of observations. And this was then the same independent of whether the patient likely had a deterioration or not. And this leads to some decay in the performance. So this in orange is the ROC for the system with all data. In green is the performance of the system with the removed data with a lower time resolution. And we see there's some decay, but it's not a major decay. Also, when you look at the precision recall curve, you see the precision goes down maybe from 42% to maybe 30%. There is some decay, but mostly because there's less information available. So the conclusion is there's no major performance loss when monitoring density is normalized, but there's some. So the system predicts not only based on the monitoring intensity. So, of course, it's also very important to assess the system on external validation. And for this, we use the MIMIC data. This is a data set from a Boston hospital. And we trained the system on our data set from Bern. And then we applied the system to the MIMIC data directly. So, and this is the orange curve here. So, and this curve here is when you train on the Bern data and test on the Bern data. So you see there is quite a discrepancy between this curve here and this curve here. So this can have many different reasons. So first of all, the performance of this trained system on the HIRIT data, on the Bern data, on the MIMIC data is still reasonably good, but the performance, there is a performance drop. So if we actually retrain the system on the Boston data, the performance gets significantly higher. So it's these green curves here, but we don't reach the performance of the Bern data set. And we figured out what the problem is, and the MIMIC data. It turned out that the MIMIC data has a lower temporal resolution. It only had data every hour, not every 5 minutes as we have it for the HIRIT data, for the Bern data. And this fully explains the performance drop between the orange and the MIMIC data. So if you downsample the HIRIT data, the Bern data set to the same time resolution, then we get roughly the same performance as on the MIMIC data. So this is a difference which comes from data sets. So generally, what we can conclude here is, yes, the system can be applied, and a trained system can be applied to other hospitals if we reduce to these 20 variables, but there's some loss in performance, which can be corrected if one uses data from that hospital to retrain or fine-tune that system. But that is all good, and it's mostly, let's say, a computation exercise at that point. But to really bring these systems into the hospital we face some additional challenges. Some of these challenges are IT related. So we need to have IT infrastructure to run these algorithms in containers or so. We need a real-time patient data management system integration to get the inputs into the machine learning algorithms. And we need to integrate with a notification or a display system or a beeper system near the patient bed. But also there are challenges related to the model itself. So it needs to be adapted to the hospital, as I mentioned, with domain adaptation or transfer learning. We actually need to implement methods for continuous monitoring of the prediction performance, because many things can actually happen. In a patient data management system, variables sometimes get renamed, and then suddenly a variable is missing or not available to the system anymore. And then the performance of the system would significantly deteriorate because some of the information is not available. So it's not sufficient to just run the algorithm. On the bedside, it also needs a watchdog monitor, which monitors the performance of that system and assesses the performance and whether there's any decay in the performance or any drift and so on. And of course, if we run this in the hospital, we get more training data. We would like to regularly train and adapt to new data and maybe new policies. And there's additional challenges in clinical practice. We need to provide explanations why certain alarms are raised. We need to work on visual representations of these model outputs. We need to train clinical personnel to properly use the system, to not over-rely on that system. It's very important. And of course, to really prove the efficiency of that system in clinical care, we need to have an interventional clinical trial to show that some patients, those patients which have that system in use, have a better outcome than other patients which don't have it. I would like to briefly go into 2 points here before I finish. So one is related to the IT infrastructure. So The difficulty in this case is that those people who develop the AI methods and computational models on one hand, on the right, and those people who run or in medicine near the patient bed are quite separated. There's quite a big divide. We can get data from the hospital into the research setting and develop these methods as I've described. But it's very important to package then these different methods into some container, which can then be delivered into the hospital and run in the hospital. So this cannot necessarily run outside of the hospital unless there are special circumstances. So the idea is that we have containers, and these containers are developed by data scientists. And these containers could then be run in the clinical setting as clinical use cases. And the use case of an early warning system, which I've given you, would be one of these. But we need infrastructures like these. And this is here a slide which I worked together with Michael Krauthammer. That's one infrastructure which we need in order to run the predictions, such models in the clinic. The second one is we need advanced tools for visualization. So what you see on the right here is a patient visualizer, which we have developed to browse the raw clinical data. So the time series, the predictions, so you can scroll in, you can scroll left and right, zoom in and out, add different variables and so on. And also get the prediction scores. And this is very important for physicians to see why a certain prediction was made this way and so on. And this is a research tool, but it also needs to be implemented in the clinic when one shows the predictions. And finally, we need methods which can help us better understanding the current patient health state. And we have worked on methods which can do this, where we have a two-dimensional map, and the patient would move within this map of different health states. And what you see here is two patients. One is a healthy patient, and one is a very sick patient who dies at the end, and who moves as a trajectory in this map. And in blue, you see is the Apache score, is a score how sick a patient is. And in this area, generally, you have very sick patients. And such kind of maps can be very helpful to understand, to communicate with physicians how a patient evolves over time, and maybe what may be wrong with that patient. So in summary, intensive care units are very data-rich environments, and they can benefit from AI systems. Current early warning system for organ deterioration lead to many false alarms and to alarm fatigue. AI-based systems can greatly reduce the number of false alarms. And we have done this for circulatory failure, and we have ongoing work for respiratory and renal failure systems. So the clinical use of AI systems is non-trivial and needs addressing core challenges. And I mentioned the challenges on IT integration for real-time use, the continuous monitoring of and improvement of these models, and also to develop efficient physician AI user interfaces, the proper training, and also the clinical validation. And this is a lot of work which needs to be done. So ongoing work is along these lines. I mean, on one hand, we develop new methods to deal with the missing and irregular data, to deal with data from hospitals, and to learn disentangled representations. But also we work on the better visualization, better user interfaces, and have studies with physicians. And in the end, we plan a multi-center interventional clinical trial to prove the clinical utility, for instance, the effect on mortality in the ICU. So with that, I would like to come to an end, acknowledge collaborators. So this work closely together with the University Hospital in Bern, also closely together with Carsten Borgwart's group. And we had a lot of support from the ETH IT services, and key drivers on my lab were Stephanie Highland, Sinrei Liu, Matthias Hüser, and also Vincent and a few others. So with that, I'd like to thank you and take any questions if there's time.
Thank you very much, Gunnar, for this fascinating real-world evidence of the utility of AI in the complex setting of intensive care. So we have time for one or two quick questions. So there are several hands I can see.
I see Mark and Daniel. I'm happy to take any of those.
Gunnar, if I could ask, first, a great presentation of precision medicine. One thing that, coming from a background where in the United States where the intensive care units are so different from hospital to hospital, I was wondering, in any way, could you use this as a quick snapshot to see how well, actually for quality assessment of the actual facility? So the issues would be how healthy are the patients and how well do the doctors do? Because actually I could see where that would be a really valuable tool.
Yeah, I mean, so there is a data set, which is the eICU data set, and it contains data from, I think, 270 different hospitals in the US. And they're quite different data, quite different intensive care units with very different standards of care. And also, yeah, maybe the patient population is quite different. So maybe applying this system to those intensive care units would be probably a stretch because the setting would be quite different. But I agree. I mean, those systems could be used to assess how good certain actions were taken when there was a critical situation, right? So let's say you had a critical situation, was there an action made by physicians or not, right? So, and that could certainly be used to assess the quality of care. And I'm pretty sure it's not as good as in Bern.
We have time for one more question. Daniel?
Thanks, Gunnar. I was thrilled to see that question. How can we bring it into the clinic? And you have this dissemination of these three challenge groups, the IT, the model, and the practice, basically slide 18, exactly. So what from your perspective, which one of these is the lowest hanging fruit and which one is actually the last stand at Thermopylae?
Okay, I mean, I would say the first one is mostly a money issue. So I think it's an implementation issue. It needs an integration. It needs the right software company integrating it with the PDMS. And I think that is doable, but it costs money. So the second one, I think it's clearly in the machine learning domain and it's quite solvable. I mean, we know how to solve it. And I think, but there's still a few open questions how to do it right, let's say. So I think the most difficult is to get acceptance by clinicians and to really prove the clinical utility in an interventional clinical trial. So, and I think this is really the next step which we have to take. Ideally, an international clinical trial, multi-center clinical trial, where we have models which are adapted locally, and then we show that for when we have this model implemented for a subset of the patients, that these patients fare better. And you need a few thousand patients for this, maybe half a year of study. It's not very hard, but it can be done. But it's probably the biggest hurdle to get the acceptance and then the clinical utility shown.
Thank you very much.